Glod is an associate professor of medicine. That's spam. I don't know. I turned my phone off and it keeps coming back at me. To associate professor of medicine and a member of the Palliative Medicine Center of Excellence at Penn State University. She also serves as the interim director of the Woodward Center for Excellence in Health Sciences Education and director of Hospice and Palliative Medicine Fellowship. Oh, sorry, I was skipping that. And Director of Hospice and Palliative Medicine Fellowship. Her clinical work focuses on controlling symptoms and maximizing quality of life for individuals with cancer and end organ disease and other life-altering illnesses. She is also recipient of the College of Medicine Junior Faculty Teaching Award, Department of Medicine Distinguished Physician Award, Scholarship and Education Award, and Distinguished Educator Award. She has been published in JAMA and Annals of Internal Medicine and the New England Journal of Medicine, all very prestigious journals. Okay, so Sue, with that, do you want to come up or wander? Okay.
Thanks, everyone. Thanks for this opportunity. I am a hospice and palliative medicine physician. That means I prescribe a lot of opioids. My patients do not have chronic pain. They have terminal illness, life-threatening illness, mostly advanced cancer, sometimes end-stage heart, lung, liver, kidney disease. But the one commonality amongst them is that by the time they meet me, a palliative medicine doctor, most of them are within the last year of life. And so you might think, and you'd be right, that this is a population of patients who should really be excluded from any restrictive opioid prescribing policies, that these are people who are dying, who need access to pain medicine, who need to be able to get what they need to be comfortable. In fact, the 2016 CDC guidelines very clearly stated that patients with advanced cancer, patients receiving hospice or palliative care, were really outside the scope of that document. I'm here to tell you that what's written down on paper and what is happening in real life for my patients are two very different things. And that many of my patients in the last months, weeks, or even days of life are not only unable to access the pain medicine that they need, but are often vilified for trying to do so, sometimes as a result of blanket legislation and policies around opioid prescribing. In 2017, I wrote an opinion piece for the New England Journal of Medicine about my patient, Jerry. Jerry was a young man with advanced stomach cancer. And he arrived at the emergency room one day in a pain crisis because the nausea and vomiting he was having from his chemotherapy was so bad that he couldn't keep down his pain pills. He came to the ED in pain, and when the providers there opened his chart and saw that he had a remote history of cocaine use prior to his cancer diagnosis, they opted not to provide him with any intravenous pain medicine. At the same time, his bedside nurse accused him of being a drug seeker. Now, on the day Jerry got to the emergency room, he was 5'10" and weighed 86 pounds. He was not a drug seeker. He was a dying man with cancer, and we failed to treat his pain. Jerry is not alone. This year in the United States, about 2 million people will be diagnosed with cancer, and about 600,000 people will die from it. This is an extremely vulnerable portion of our population. These are not people who have the strength and energy to have a voice in opioid legislation, but they need one. My goal today is to tell you some stories about some of my own patients who have experienced the adverse effects of current opioid policies, and I'm going to end with the ending of Jerry's story. The first patient I want to tell you about is Kendra. When I met her, Kendra was a 38-year-old high-power executive who had been too busy to pay attention to the progressively worsening pain in her right hip until it got so bad she couldn't get out of bed one day. And that was when she received her diagnosis of widely metastatic breast cancer to the bone. She is among the most tenacious people I have ever met. She underwent 6 months of chemotherapy, several weeks of radiation, a surgical procedure to try to stabilize the hip, and at the end of all of that, her disease was stable, not cured. It will never be cured, but stable. And she was ready to go back to work. She started to go back to work for a couple of hours, a couple of days a week, and she was too weak to both work and go shopping, but she wanted to look like that high-powered executive, and so she got herself a subscription to Stitch Fix. And she got a case of washi tape off of Amazon. If you're not a millennial, washi tape is like duct tape. It's like the next generation of duct tape. And every day she went to work and she wrapped the washi tape around the cane that she needed to walk so that her cane and her outfit matched. She did really well for several months until the 2016 CDC guidelines came out, and you'll recall that as part of those guidelines there was language referring to the fact that there was not a lot of evidence to support the use of more than 60 milligrams of morphine per day as effective treatment for chronic pain. And so shortly thereafter I received a letter from Kimber's insurance company stating that they would no longer cover any prescriptions above that amount per day. I tried to get a prior authorization, I called them, I wrote them a letter, unsuccessfully. And so Kimber started paying out of pocket for the amount of drug greater than 60 milligrams of morphine a day that she needed. And as her disease progressed and got worse, she needed more drug. And so that went from $300 or $400 a month to $600, $700, $800, $900 a month to pay for the medication that she needed on top of all of her medical costs. Finally, she had completely drained her savings. She could not afford one more pill, and she came to the emergency department in physical withdrawal. And when she got to the front desk of the emergency department and they saw this put together, well-dressed woman with great hair and a manicure in opioid withdrawal, they immediately labeled her as a drug seeker. Once they saw her CAT scan, they realized how ill she was, but it was too late. She had already been humiliated in front of an entire waiting room full of people at our medical center. The next story is about Yvette. Yvette spent the first 25 years of her adulthood as a stay-at-home mom, raising several children until they finally got all out of the house, and she was able to pursue her lifelong dream of being a forklift operator. She was tough. You did not mess with Yvette under any circumstances, but she was also very private. And so when she was diagnosed with metastatic colon cancer, she didn't want anyone in her small community to know, except for the people who she felt comfortable telling. It was fine. I was writing for her opioids. Her pain was controlled. Her prescription, her insurance company was paying for them. And then one day I got a call from her pharmacy, because now CVS Pharmacy had instituted new rules and regulations to combat the opioid epidemic, and stated that they would not fill any prescription for an opioid greater than 7 days without just cause to do so. This was a problem for Yvette because she was her pharmacist's next door neighbor. She did not want him to know that she had stage 4 cancer. She got to the front of the line at CVS. The pharmacist would not fill the prescription without the appropriate diagnosis code. She tried to talk to the pharmacist to the side. He would not accept her conversation. And finally he said to her, "What could possibly be wrong with you that you need such a huge amount of drug? You don't even look sick." Yvette came to my next appointment in tears, and from then on she drove 30 miles out of the way to fill her prescription at a different pharmacy so that she didn't have to face that pharmacist again. Then finally, I want to tell you the end of Jerry's story. Jerry, through sheer grit and determination, lived almost another full year after the events that I wrote about in the New England Journal. And what really tipped him over the edge, ultimately, was the fact that he lived on the 3rd floor of a low-income housing unit that did not have an elevator. And so going up and down those 3 flights of steps to get to chemo, to get to radiation, to get to appointments, to get to the pharmacy, it got to be too much. And so Jerry signed on to hospice. His mom moved into his apartment with him. She helped to care for him. He had a good relationship with his hospice nurse, and his daughter, who was 16 at the time, could go to school in the day, have a normal life, and then come home and spend time with her dad. Things were good for several weeks. And then one day I got a call from Jerry's hospice nurse that over the course of a couple of hours, his pain had just skyrocketed, and his abdomen was hard like a rock. What had happened was that the gastric tumor that Jerry had been fighting for so long had finally eroded through the wall of his stomach, and now his stomach contents were spilling out into his abdominal cavity. It's about the most excruciating way to die that I know of. And so I knew that pain pills were no longer the answer for Jerry, because his stomach had no integrity anymore. We had to start an IV drip. And so I called the hospice to order the IV drip, and they called me back and they said, we have about 6 hours worth of IV medication for Jerry. This was in 2018, when the DEA had started to impose restrictions on production quotas for intravenous opioids. Those restrictions continue today, and this year there will be 10% less opioid produced in the United States as a result of this restriction. At that time, multiple centers, including academic medical centers, were reporting shortages of IV opioids, including at MD Anderson, who reported that they were able to demonstrate less good pain control for their hospitalized cancer patients because the medical center itself was unable to get the opioids it needed. We were in the same boat. We called around to every local hospice. Nobody had any IV drug. We called the infusion company that serviced not only the hospices in our area, but also several local hospitals in the Harrisburg area. That infusion company that serviced all of those hospitals and hospices had about a 1-week total amount of IV drug that it was going to have to distribute to all of those different centers. This is not just people who are dying on hospice. This is people in the hospital who just got surgery, people on ventilators in the ICU who need opioids for sedation. And so they wouldn't give up the drug, and I couldn't blame them. They needed that drug for so many other people. And so finally I did something that was extremely hard, and I called Jerry and I said, look, you gotta come in to our hospital. I can't get IV drug for you at home. He was devastated. I mean, he hated the hospital. That's where he went to get accused of being a drug addict. He wanted to die at home. He wanted to be with his family. Finally, the pain just got so bad that he agreed to come to the hospital. I would like you to imagine what it must be like to be carried down 3 flights of steps on a gurney by EMTs, take a 30-minute ambulance ride through the potholed streets of Harrisburg, and then sit for an hour in the emergency department waiting room, all with absolutely 0 pain medicine on board, with an erosion in the wall of your stomach. That was how Jerry died. When he finally got to the emergency room, I went down, I met him there, we ordered the drug. It seems like it took forever to come up from the pharmacy. It was only 5 or 10 minutes. And I started the drug, and finally he was comfortable. And once he got comfortable, I did something that I have never done in my 12 years as a hospice doctor, which was to hope that he would die quickly before the drug ran out. Because once it did, I had nothing. There was no backup plan, there was no drug, there was nothing. Jerry did die comfortably later that night, several hours later, and we had enough drug to see him through that. My perspective is I'm not here to argue against opioid legislation. This is a tremendously important national crisis that we face. But the question that I would ask is, what amount of suffering are we as a society willing to accept as collateral damage on the part of this extremely vulnerable portion of our population? These are people who don't have a voice. There will never be a stage 4 cancer patient march on Capitol Hill. It's not going to happen. They're too tired, they're too weak, they're too sick. And when they do have a good moment, they want to spend it with their family, doing the things that they love. They don't want to spend it coming to a place like this. But this is still a portion of our population who need an advocate. They need a voice. And the reason why I'm here today is to hope that maybe that voice can be you. Thank you very much.